Hello, and welcome to Collaborative 101. This is February 16th, 2018, when we are recording this. As you know, things change, so if you are watching this significantly after that time, you'll want to check in with the BHT team to see what changes have occurred. The purpose of today's session is to provide you with a working knowledge of our collaborative structure and get us ready to get to work. The BHT vision is to ensure that everyone in our region, regardless of environment, background, or life experiences, will live a productive quality of life by ensuring access to integrated whole person care, stable housing, food, and transportation, as well as the opportunity for education and training that allows for meaningful employment with a little bit of extra money left over to pay your bills and save. And finally, important to all of this is strong social support networks. When we think about the vision of BHT, it's really important to note that we are talking about how do we connect not just the healthcare system with our social determinant of health system, but also inspiring people to take control of their health. The road to the development of our accountable community of health transformation collaboratives really started back in 2013 when BHT launched as the lead organization for the in-person assister network and signing people up for health insurance related to the Affordable Care Act. At that point, BHT was a fledgling organization, and we had an audacious goal to sign up 10,000 people for health insurance in the first 2 years. We wowed ourselves a bit by signing up a little over 100,000 folks in the first 18 months of the Affordable Care Act. That's both a tribute to a hardworking BHT team, but probably more importantly, and what's baked into the DNA of BHT is the set of community connections that really put people who are trusted in a community in a position to help improve people's health. So as we think about our accountable community of health work, that is really embedded in all of the things that we think about. In 2014, the governor launched the Healthier Washington initiative that included a $65 million Centers for Medicaid and Medicare Innovation grant to support the development of several key items that included getting ready for value-based payment, developing regional structures, preparing the workforce, and practice transformation. Paralleling our in-person assister navigator work was the formation of the Accountable Community of Health. The Accountable Community of Health really came on the heels of some excellent work that had transpired over the previous 3 or 4 years amongst health leaders and really gave some form to developing a regional health collaborative structure. As we moved through the SIM process, BHT led a very comprehensive community priority setting activities, and in 2015 formally adopted those activities. This then led to some continued designation as the region's accountable community of health. As we move into 2016, we took these 5 priority areas and started to map them to our community assets and opportunities for improvement. As we were doing that, one of the key themes that came forth was the need to coordinate the coordinators. And it didn't matter whether we were talking about priorities related to health or obesity or stable housing, this idea of who was playing air traffic control for all of the great work that was transpiring in our community. This led BHT to select the Pathways model for our regional health improvement plan, working to demonstrate a multi-sector solution for one of our priority areas. The launch in 2017 of a pilot Pathways project in Ferry County really served as a jumping off point for our region's Medicaid transformation work. So in early 2017, the state of Washington and the federal government through the Center for Medicaid Services agreed to a $1.1 billion waiver that really gave us the working capital to take the planning we had done through our regional health priorities and our designation as an ACH and pathways work and really start to build towards true delivery system reform. Throughout the year of 2017, we passed a number of significant milestones that get us ready for the launch of our collaboratives, including earning $6 million for 2 rounds of certification with the Healthcare Authority and some really important policy work that the county commissioners did, agreeing to be a mid-adopter for fully integrated managed care. And in late November 2017, Better Health Together submitted a $10 million project plan. And we heard in early March that we received a 100% score, earning our region $10 million, which really brings us to today and the launch of our collaborative structure. We see the community health transformation collaboratives as building the networks that are going to be necessary to really reform the delivery system for the Medicaid population, as well as prepare our healthcare and community partners for value-based care. When we think about Medicaid transformation, we've really broken this work into an equation that if we meaningfully transform the Medicaid delivery system, we pair that with scaling up a robust and connected regional infrastructure, pay attention to continuing to improve health access, and a common theme through all of our ACH work is really closing health disparities and improving health equity. If we do all 3 of these things, we believe that will add to an accelerated improved population health, which is good for our communities. Furthermore, as we think about this framework, we have identified some key settings for our Medicaid transformation work that will be critical to really link together the healthcare system with our social determinant of health system. So at the top of the graph here, you see a number of settings that we've identified that will be necessary to make the transformation come to reality. And these will be the types of partners we expect to be actively participating in our collaboratives. We also need to think about the regional infrastructure that will be necessary to really sustain this improved delivery system, from ensuring we have enough people to actually do the work, a financing mechanism that allows for us to make upstream investments to really get to population health, the right set of technology, partnerships, advocacy, policy changes, as well as just a continued focus on it's not just your health care delivery system that makes you healthy. It is also the social determinant of health system that makes you healthy. Because thinking about the 174,000 Medicaid people in our region feels a little overwhelming, we have identified some target populations to work with. First, looking at people with opioid dependence. We all know that that is a significant crisis in the region, across the state, and actually across the country. We have a very strong but lacking in access population of people with behavioral health. So as we think about these transformation opportunities, we think there is an incredible community benefit by focusing on that population. And oftentimes what we find is people with behavioral health problems also have chronic conditions. So if we can really think about those 2 populations being tied together and building a system that supports the improved health status for those folks, we will be well served. Additionally, as we thought about pathways and how to really scale up a community-based care coordination effort, we have identified women of childbearing age and people transitioning out of jail as really a target population for us to focus on with our community-based care coordination efforts. And finally, as we thought about how to structure this work, we wanted to note that both transitions of care and diversion strategies will be important to really infuse into all of our work. While we didn't select these as core project areas, we think there is a very natural connection point to the settings and infrastructure we think we need to build. The big question, I think, on everyone's mind is how are we going to actually move the needle, and what needle are we trying to move? It is important to note that how the region earns money is different than how our individual partners and collaboratives will earn money. The first column here on the state measures are a highlighted set of state measures that both ACHs, MCOs, and the state will be accountable to in order for the state and the region to earn dollars. These are things that we've all been talking about: increasing the number of Medicaid contracts that are value-based, reducing ED utilization, certainly looking at treatment penetration rates for mental health, substance use, and the great opportunities we have to really reform the medication management system for a more connected approach. We've also thought a lot about the opportunity to develop some ACH specific measures. So you will remember that over the last year or so, as we sort of debated are we going to do 8 projects or 6 projects or 4 projects and then 6 projects some more, we wanted to really infuse some of our priority areas with some of this work, but not being tied to the models and the measurements that the Healthcare Authority set out. So these ACH local measures that we expect that the BHT board will approve on February 21st really reflect those community priorities related to jail recidivism, reducing unintended pregnancies, improving oral health, and increasing behavioral health access. We've set some targets in this, and over the course of the next several months, we will refine those, both in the activities that we think will drive us to reducing or improving those measures, but also the set of activities that will be tied to it. And finally, we want to give our collaboratives enough flexibility that if there is a particular local issue that the collaborative is interested in taking on, there is that opportunity. We consistently get questions about who's doing what and where do the decisions get made. In that flavor, we wanted to share this information with you. And I would say that it is critical to acknowledge that the ACH is really the compilation of people and partners that are working in this work, and that in the role of BHT as an organization is really to act as a driver of the agenda, but not as a doer of the work. So we have identified these community health transformation collaboratives as really the doer of the work. We like to refer to them as really our activation networks. We'll structure those in a 2-part area. One as the Spokane County Collaborative, and then our Rural Collaborative, which will be comprised of county-based efforts in each of our 5 rural counties. We'll move into, on the next slide, who is in the collaboratives, but I think thinking about these groups as really the people who are doing the work. Many of you have been participating in our Leadership Council over the last 3 years, and while we continue to aspire to use that group as a strategic synthesizer, we have identified there's just a high need for really some technical advising as we move into the requirements for our collaboratives, both on a clinical, financial, and community input process. So to that end, we've established 6 technical councils that will serve as advisors to the BHT board. The first is our Provider Champions Council. Their main job will be to set the clinical setting requirements for our work. They'll be looking at the requirements of our bidirectional opioid chronic disease work, as well as some of the other key areas that we've identified through our priority process around oral health and maternal and child health. The Community Voices Council will serve as really the community accountability system. that group is comprised of at least 51% Medicaid beneficiaries, and they're going to help us, in addition to really provide the gut check on is the change that we are trying or proposing to create going to actually work for people who are in the system. But they will also be charged with helping us to develop a actionable plan for really improving health equity. The waiver finance group is just what they sound like. They will be accountable for developing the financial funds flow for our waiver dollars as it relates to our project money and our fully integrated managed care incentives. And then the Community-Based Care Coordination Advisory Council, or the BHT Hub, as we're now affectionately referring to it, will set the requirements for community-based care coordination in each of our settings, as well as really be charged with how do we create an integrated set of infrastructure with shared technology, shared resource, shared training, so that we really raise the interconnectedness of how we're delivering care coordination. Our Tribal Partner Leadership Council, which has been operating for a little over a year now, will continue to provide a direct link for all of our technical councils, our collaboratives, and our board to ensure that none of our plans have a disproportionate effect on Native Americans. And furthermore, really trying to build a healthy network of tribal health providers throughout the region that can both access our ACH investments to improve the delivery system, but also the statewide tribal ACH. And then finally, our regional integration team is comprised of healthcare, social determinant of health, county commissioners, and MCO leadership that was instrumental in really bringing together the right conversation in order to develop our fully integrated managed care plan of attack for the region. This group is on hiatus right now while we sort of move through this initial phase of FIMC readiness, but we expect that they will come back together both to ensure there is a strong linking between our FIMC preparation and our transformation preparation, but also looking at some of the policy issues that we need to address at a regional level. All of these technical councils are where a lot of the advising work is going to get done. Most of the process is driven by our council chairs and staff really putting together a set of recommendations for the council to give their perspective on, and then forward those policy recommendations to the board. We have strived for diversity of provider type, geography, size of the organization, etc., to really ensure that we are representative of the full region. Finally, the role of the board is ultimately the governing body for our accountable community of health. And so they make the final decisions on all things related to the Medicaid transformation project activities. One of the things that I think is really important to note here is that the BHT board, while receiving these policy recommendations from our technical councils, is really committed to not making different policy decisions than the recommendations coming out of our technical council. So while we're not saying the board is rubber stamping everything that's coming through, we have an agreed upon process that if the board disagrees with a recommendation coming from our technical councils, that it will go back to the technical council for some further exploration before making a final decision in that way. So it's a slightly complicated governance structure, but I think it really balances out our both geography, diversity, but also the diversity of partners we're trying to do, while trying to ensure that we can be extremely nimble and move quickly as the landscape both continues to shift and to make sure we get to action as quick as possible. So now the exciting part. So who is actually in the collaborative? We spent a lot of time figuring out how to really support this idea of natural systems of care and the right set of partnerships that will be necessary for the region to meet its value-based goal targets. So to that end, we've identified these different settings. In a rural community, there is probably only one or two primary care providers. There might be only one mental health and SUD provider. But in Spokane, you can imagine there are a number of these. But we think every collaborative needs to have a partner representing each of these settings, developing an implementation plan for how we meet these objectives. I think it's important to note that we have a very important role and relationship and value of partnership with our managed care organizations. And so we're placing them in these collaboratives, but they are not going to be recipients of any of our waiver dollars. Our waiver dollars will just flow to these provider and partner organizations. I would highlight a couple of things on here. One is that we have really prioritized food, housing, and transportation as social determinant of health partners that need to be at this table. It's important to note that those partners are really critical in how we sustain health improvement, but they're not all of our social determinant of health partners. So we want to leave some flexibility for some of those other key partners, whether that relates to education or some other sort of target social determinant of health that will be important to move the dial. And we really were prioritizing those relationships around food, housing, and transportation because those are the three top social determinant of health priorities we heard about. Additionally, I would note that we are specifically calling out Native health providers on this slide, or tribal health providers, though for most intent and purposes, we really do see them as part of the delivery system, whether it is as a primary care or a mental health and SUD or oral health provider. So as we move through this, it would be important to note that piece as well. So as we think about rolling this out, what is the collaborative's work for the coming year? And we expect to be providing on a monthly basis sort of some rolling guidance as we move through this process. I hope you'll appreciate the fact that our BHT team is working really hard to stay a step ahead of everything. And it is complex work, and we are trying to push information out as clearly and succinctly as possible to give our partners maximum amount of time to respond, which is why we're not holding everything till May when I can give you a nice little package of this, but you'll see it in a very ongoing rolling manner. So the first step is that we would expect each partner to sign a letter of commitment, and we will launch that on February 22nd. Which will give folks an opportunity to really start to say, yes, I am in, I want to participate in this, and for the region to be able to see, are we missing any of those key settings in any of our geographical areas? The next step is to conduct an assessment, inventory, and gap analysis. We're going to really emphasize these assessments as they relate to behavioral health, physical health, emergency department, and pharmacy settings at the outset, because those 4 settings will be really critical that we have implementation plans developed by early summer so that we get ready to submit our planning documents to the Healthcare Authority to earn our year 2 investment. We are also looking at how we develop sort of strategy assessments for our other partners. So as we think about value-based payment and how we're linking the healthcare system with the social determinant of health system, we want to make sure we're preparing our partners well to really be a value add to that discussion. As I mentioned on the earlier slide, we want to give the collaboratives an opportunity to develop collaborative level goals. So that's sort of be the next step in the process. So you know who your members are, you're starting to take the assessment. Are there additional goals between the groups that they want to highlight as part of the collaborative's work for the upcoming 4 years? We don't have a strong preference on whether this happens or not. We sort of expect a couple of our regions will be like, nope, we're super focused just on the core work that needs to be done, and others might say, gosh, there's a lot of community passion around this. We want to have that be part of it. Finally, we will move into our implementation planning process. So very specifically, our behavioral health, primary care, emergency department, and pharmacy settings will be required to submit formal implementation plans by June 30th. Don't worry, we're going to give you a nice guidebook and some support to be able to develop that. That'll really be the foundation of the region's implementation plan that we have to submit to the Healthcare Authority in October. We see this as a very collaborative process, but is focused on building really the business case and implementation plan for those settings to get ready to move the needle on a number of these metrics. We wanted to prioritize that so that we had sort of maximum time to not be in a fire drill trying to get our final report to the Healthcare Authority. We expect that the other settings that we've identified would also have an implementation plan. They would just have a little bit more time to develop that because we aren't going to have to share those plans with the Healthcare Authority. Finally, I think one of the things that will be of interest to everyone is really how are you evaluating these plans? And we're really clear that at some level, these are individual organizational strategy plans for how they both compete and collaborate in the marketplace. And so we want those plans to not be, I'm trying to chase money, but really grounded in good business strategy. So we don't see a significant role for BHT to say, we like your plan or we don't like it. What we're really going to be looking towards is validating that indeed the plans that have been developed will actually lead us to being able to achieve our metrics. So that validation will occur in a couple of different ways. One, we expect to take members of each of our technical councils and do a high-level review of each of those, provide some feedback to individual partners and the collaborative. And then we'll really rely on the BHT staff and our consulting team to do more subject matter expertise in terms of will this work for the whole region? We expect this to be not a you pass and are funded, but more of a collaborative effort in that way. And then finally, we have hired an organization called Providence Core to really develop some targeted evaluation projects for us so that at the end of this period of time, we have a good business case for why this intervention or that intervention will actually lead to improved health and cost savings. So things that we imagine we will evaluate would be the Pathways program, possibly a community-based paramedicine program, things like that that we think are evolving practices, but maybe don't have the evaluation tied to it. Then we get to the money, and this is a little more squishy than I think many of us would like it to be, but this is directionally accurate for us to think about how many dollars there are and how we would spend them. So as those of you who've been following along know that towards the end of last year, we committed our project money with a allocation methodology of 30% to regional infrastructure, 55% to the collaboratives, 10% to our community resiliency fund, and 5% to ACH administrative costs. We are in the process of releasing our set of first round of funds flow for the collaboratives. And each month or so, we will continue to talk about how we would imagine allocating those dollars. There is a lot of interest in the Community Resiliency Fund and what types of things that would fund. We are just launching through our technical councils a principle/framework discussion to really define those. But the board approved the 10% of the dollars earned in the region to go to this Community Resiliency Fund with the idea that this would be used to invest in the social determinant of health system and how it will connect with the healthcare system. Increasingly, we're talking about how do we get the best leverage for those dollars and ensuring that it is a targeted investment that will really move the needle on the work that we need to. The other funding bucket we have access to is the fully integrated managed care incentive dollars. We earn $8.6 million for being a mid-adopter. The Finance Committee recommended to the board that our year one funds be focused on the behavioral health providers. So we have about $3.1 million that we intend to invest with those behavioral health partners. We are still working out the timing of when those dollars will be released. So you'll want to check our website regularly for that. The final thing that I think is really important in the collaborative development is really how we think about these project funds. And when we first started talking about $1.1 billion, it sure seemed like a lot of money. And even when we were still at the $80–90 million of locally controlled dollars, that seemed like a lot. But when you start looking at potentially 130 plus settings in our region across 6 counties, the number of partners that means, those dollars don't stretch a real long way. So it's going to be really important that at a collaborative level and at an ACH level, we're really thinking about how do we leverage those dollars so that we get the best impact from that. So we've identified a number of potential partners that we can be working on. But some of this is not work the ACH can do as much as it is our partners needing to really work with the influence that they have and making sure that we're really getting the best return on our investment. So we're excited to really support this work and would just invite you as we think about who should be and what is the funding mechanism that we continue to have a lot of conversation and work to the betterment of the entire region. Thank you for your time. I am sure that this is evoked some additional questions, so please don't hesitate to reach out to the Better Health Together staff. You can find additional information on our website at betterhealthtogether.org. And with that, let's go and radically improve the health of this region. Thank you.